So I think the first presenter is Jill Gorham.
Thank you. Perfect. Okay, good. Thank you very much for allowing me to present today. I'm going to be talking about a study that was part of my thesis. And before I start, I'd just like to acknowledge the traditional owners on the land on which I work and live. That's the Larrakia people in Darwin, the elders past, present and emerging. So this study was part of a broader project, and the aim of the study was to look at the costs and benefits of dialysis services in different locations, so urban, rural and remote. And for this component of the study, I used clinical and administrative data as well as financial data. We do have a very large qualitative component associated with this project, but I'm not talking about that today. So the three components are looking at the cost of dialysis services by location and by modality. And I used all the available data that was available, I suppose, to myself. It was government and non-government funded services. And then I looked at dialysis attendance and hospital admissions and their hospitalisation usage, including ED presentations by each model of care. We included interstate travel because we wanted to make sure that we weren't identifying people as not attending dialysis services when they're actually interstate or in hospital somewhere else. The costs were based on ANDRG, so all-cause hospital admissions, including dialysis attendance. And we used a number of analytical methods, I suppose, to look at looked at factors that would influence a high cost or a low cost case mix. The reason why this study was so important is because the majority of people on dialysis in the Northern Territory are Aboriginal and they come from very remote locations. So the map on your left shows all the remote communities in the different, all the remote communities where at least...
12,000 photos on my phone. 12,000! And the worst thing is, I never even...
Sorry. We're at least 2 people who have renal disease and were required to relocate to the urban areas to have dialysis. So the map on the right-hand side is actually where all the renal services were located at the time of this study. So we categorised services by the type of service they delivered and the care they delivered and where they were located. So in the Northern Territory, hospitals do deliver dialysis as an outpatient. So because usually our services are quite at capacity and stretched, so hospitals are used for overflow. So the 2 new tertiary hospitals, one based in Darwin, one based in Alice Springs, had outpatient services. Model of care 1 is urban services. So they were located quite close to the hospital in the urban area. Very large satellite units, 26 stations, and there was 2 in each of the main towns, Darwin and Alice Springs. Model Care 2 is associated or co-located with a rural hospital. So they were actually on the grounds of the hospital and smaller facilities, 6 to 8 chairs. Model Care 3 is a remote satellite unit based on the Tiwi Islands. This was the very first remote unit in Australia, and it was actually established through lobbying from the local Aboriginal people. Model of Care 4, most people in Australia know this as the Purple House model. So this is an Aboriginal owned and driven organisation that established, raised $1 million to set up dialysis services, and over the years established a number of different sites. So from about 2004, they had small 2-station facilities located in very remote areas where they primarily provided respite dialysis to people who were in Alice Springs. Over time, they've spread and now they provide services in the top end. And Model of Care 5 was self-care dialysis. So people doing home hemodialysis but couldn't dialyse in their own homes. The government, both the Northern Territory and Australian governments, provided these 2-station facilities which we designed and were relocatable. And they were placed in communities where people's homes were not suitable to provide self-care dialysis. So they could go to a safe, secure place where they could find a machine and they would be able to do their dialysis. So the first part of the study just looked at the cost of providing services by program. So it was a ground up study, microcosting analysis. As I said before, we used all available data to us, and where we had missing data, we standardised the missing data through PBS, MBS items and published literature, and also using the national efficient price. And what we found wasn't surprising. So those facilities in remote areas cost more, primarily because of the infrastructure and the staffing model. So staffing model was a big driver of costs, and certainly for the remote areas where the model was based on a fly-in, fly-out service. So remote model 3 actually had a very frequent rotation where they were going in and out on a weekly basis, whereas 4 would stay for 4 to 6 weeks. The difference between these two models is interesting because remote model care 3 is a single standalone facility, whereas 4 is 8 sites aggregated data. So, and because of their model is there's many staff, I suppose, but it's still a fly-in, fly-out model, even though they have opportunities to create relationships in the community because they spend longer time there. The rural model, there were some cost efficiencies there because they were able to share supply lines, storage rooms, staffing. So it was very difficult to separate some of those costs out. And for us, Model Care 6 was more expensive than some of the literature that we found. And that was because majority of people used APD, so automated peritoneal dialysis, which is a machine and fluids, and they were more expensive than the home hemodialysis machine and fluids was. The next step of the analysis looked at dialysis attendance. So we aggregated data over 6 to 7 years. We had 1,003 patients. The majority were First Nations, so 896 people, and the majority of them, 85%, were relocated from remote area to start dialysis in the urban area. So we looked at dialysis attendance by where people were dialysing, and what we did was we created the model by looking at where people had attended services for the previous 3 weeks, and we rolled that forward by a week, so that if someone had a hospitalisation, we were actually attributing that hospitalisation to the correct model of care. And we did find that people bounced around between services quite frequently, especially between the models 4 and 5. So we wanted to make sure that we were attributing a hospitalisation to the correct model. We also looked at ED presentations and admissions that we believe were associated with missing dialysis, such as fluid overload and hypokalemia. And we did sensitivity analysis looking at age, comorbidities, dialysis vintage, how long people had been on dialysis, and how often they attended, and also the model of care. And that's currently under review, that paper. So what we found was that male gender was closely associated with lower dialysis attendance, as was being relocated, particularly from the very border communities along the Central Australian border communities, so into South Australia, Western Australia. Most people who were relocated and dialysing in the urban areas, that's Model Care 0 and 1, time on dialysis of less than 4 years, and younger age groups. And this sort of fits with what we know of people starting dialysis, that the shorter time on dialysis, being male and younger, often means that you have much lower dialysis attendance than anticipated. So just looking at the graph there, 156 is the ideal. That's people turning up 3 times a week as prescribed in the Northern Territory. And so you can see that when people are down around that 90, 100 treatments per year, their health is really going to be impacted. And that's exactly what we found. So when we looked at the risk of hospital admission by all these other factors, those same factors played a part, and particularly people from remote areas, people with comorbid conditions such as diabetes and vascular disease and dialysing in the urban areas. The risk of a hospitalisation was twofold for people from remote areas dialysing in centre, and particularly also if they were in the Central Australian region. So then we try to put all of this information together, the activity and the costs, and we looked at hospitalisations, all-cause hospital admissions, using ARDRG cost weights. We then inflated using the Health Price Index from $2,014 to 2017. We used the published study on the outpatient dialysis cost to bring in the cost of infrastructure and outpatient dialysis treatments. And we used some sensitivity analysis to look at not worst case, but low cost, high cost case mix scenarios. So these are just the top 3 DRG admission reasons by each model of care. And so you can see that the model of care 0 tends to have higher costing, the DRGs that cost more, and so does model of care 6, and that's because people ended up with more complicated conditions when they were in hospital. It was infection, it was peritonitis model care 6 is peritoneal dialysis, if I didn't explain that beforehand. And so the average cost for those 3 conditions varies, but certainly peritoneal dialysis is quite expensive in terms of hospital admissions. We looked at the person years for each model of care so that we could then break it down but for the mean annual costs for hospital costs, dialysis costs, ED costs, and then look at the total service costs by each model of care. And you can see now that the incremental and marginal cost differences between each model is now reduced when you add all those hospital costs in. And so model of care 3 and 4 aren't that expensive now when you compare it to model of care 0 and 1. This is what it looks like on a graph at the mean annual costs. So the blue are the hospital costs and the orange is dialysis program costs. So we did look at the factors that might influence or impact on a low cost scenario. And it was interesting that we found that, so being female from the urban area, 50 to 60 years of age, and dialysis vintage or on dialysis for 4 to 5 years, and on-home hemodialysis would incur an average of $25,000 in hospital costs per year. But on the other hand, a female from a remote area who was able to dialyse in a remote area, with all other things being equal, would also incur the same amount. On the other hand, males come from a remote area, relocated and dialysing in the urban area, short time on dialysis, relatively young, and possibly with a vascular disease or another comorbidity, would incur a cost of about $100,000 each year in hospitalisations. So, in summary, remote dialysis do cost more, but relocated people have lower dialysis attendance and higher hospital health service use when they're in the urban area. Inverse, I should say, is when they're able to dialyse in a remote area, then they actually have better attendance, fewer hospital admissions, fewer ED presentations, and overall better health outcomes. So the outcome of that, I guess, is that the incremental cost differences between models is vastly reduced when you consider all those other factors. Thank you. Any questions?
Thank you, Gillian. That was a fantastic summary and a review of the paper. We do have a question that's come through. Thank you, Rachel. So just a comment is, thank you, great paper. Gillian, do you know which models of care produce the best health outcomes in terms of survival or quality of life and well-being, and which model people prefer, the patients themselves?
So people definitely prefer to dialyse at home or close to home. So a part of this work is looking at what makes a good life on dialysis, and we're working with patients and Aboriginal co-researchers to try and create a value for money framework around this so that patients can have input into these sort of policy decisions. Definitely model of care 3 and 4 had better outcomes. And when we looked at survival, those patients that were able to stay in the remote areas longer had better survival than those people that were relocated. So it was possibly 8 to 12 months in terms of better survival.
Thank you. And just a comment from Sophie that it's going to make a difference to so many people and families, which kind of made me wonder the pathway to implementation, Gillian, what might be next steps in terms of supporting some policy or program change through this evidence?
So this, I guess, has already supported some policy. So you may know of the MBS item 13105 that allows people to have dialysis in a remote area if they're supported by primary health service. So this work actually informed that reimbursement amount for the MBS item. And now we're working with the Department of Health to try and support more hybrid models in remote areas. So a cross between using those relocatable facilities to provide a combination of self-care and supported dialysis. So it provides The hybrid model provides some support for self-care patients who are dialysing by themselves. When there's somebody there who's not actually doing their dialysis, but they're available if they run into a problem and they might be looking after somebody else.
That's great news. Thank you. Thank you so much for the presentation. And if we've got no further questions, I might hand over to Amy Dennett, who was the runner-up in the Early Career Researcher Best Paper, and she'll be talking about her paper on exercise, evidence-based exercise therapy for cancer patients. Thank you, Amy.
Thank you. So hopefully that's coming up on the screen now. So thanks for the opportunity to talk, for me to talk today about our implementation study that we did about implementing exercise co-located in a cancer treatment setting. So a bit of background to this study. Oh, here we go, it's working now. So we've had a rapid increase in growth in the research about exercise and cancer over the last 10 to 15 years. It's relatively new compared to other areas of rehab, such as pulmonary and cardiac rehab. So we have a lot of gold standard evidence that exercise is beneficial for cancer survivors. It improves their quality of life, their symptom profile, and it even might improve their cancer outcomes, such as preventing recurrence and reducing the risk of early death. So as a result, we have a whole bunch of guidelines that have been released, particularly in the last 3 or 4 years, that we should be implementing exercise as part of standard cancer care. However, when we did a bit of a benchmarking study back in 2015, despite 1 in 2 people being diagnosed with cancer, only about 1 in 200 have access to a specialised cancer rehabilitation program within the public hospital system in Australia. So there is a huge mismatch between the need for exercise and cancer services and the actual access that they're getting. And there's a whole bunch of reasons for this. Part of it, especially historically, is just a lack of awareness about the benefits of exercise and cancer. And this has gotten a lot better in the last few years since the COSA statement was released. Also things like clinicians just not referring to programs that even do exist. So we've got a lot of work to do to catch up to our cardiac and pulmonary rehab colleagues. So one of the movements that there's been in the oncology space is this assess, advise and refer message that specialists in particular have been encouraged to send people to an exercise specialist such as a physio or an EP. So I work for Eastern Health, which is one of the largest health networks within Victoria. And at the time of doing this study, I was working clinically in our subacute oncology rehab program at One Turner Health, which is that lovely multicoloured building there. And this was the first program of its kind that was set up in 2010 that offered exercise and education to people with cancer. And in 2017, there was more and more research coming out, especially for people who were receiving cancer treatment and the benefits that earlier rehab had. And we were seeing quite a growth in numbers to our cancer rehab program. We receive about 3,000 admissions per year for people with cancer. The waiting list was growing to about 6 months to get into our cancer rehab program. So we really felt there was a need to expand our services. So we did a scoping study back in 2017 and we asked clinicians and patients about what they thought about having early rehabilitation during cancer treatment. And the things that they told us was that it really needed to be convenient. So one of the big barriers to getting people into an oncology rehab program is just they're overwhelmed with appointments, parking is difficult, so location is really important. It had to be individualised in terms of the timing when they feel ready, but there also needs to be adequate resources, including access to skilled staff, as well as awareness of there even being a program. So when we did these interviews, we'd had a program for about 7 years, but there were still nurses in day oncology that had no idea that we existed. So promotion was really important. So we designed a program and then a subsequent study to see what the effect of a co-located cancer exercise rehab program would be. So we know that exercise and cancer is beneficial from randomized controlled trial settings, but we really wanted to know, can it actually work in a pragmatic cancer treatment setting? So we did a pre-post study where anybody with cancer, whether it was early or advanced cancer, could attend this program. They had to be either preparing for or receiving cancer treatment, as traditionally most people are referred after cancer treatment has finished, and often this is when people have already developed problems. They had to be reasonably well functioning, so living independently in the community and independent with their activities, cognitively alert and medically stable. So we had a physio-led program. So there was 2 physios. Participants exercised for 8 weeks. It was individually tailored. And one of the key differences with this program, it was that it was a bit more flexible than a traditional program. So we offered sessions on 4 days of the week. We coincided this with the middle of the day, so we could capture people coming in for chemo in the morning and the afternoon sessions. They also had the option of whether they wanted to come once or twice per week, and they also had the option of whether they wanted to do a hospital-based exercise program or a home exercise program, knowing that sometimes these people might not necessarily want to be coming in for additional appointments. And regardless, they received an 8-week follow-up. So we used Bowen's feasibility framework to look at the feasibility of this program, and we chose 5 domains. So we looked at the demand for the program, practicality, implementation strategies, the acceptability of both patients and staff, and the efficacy of the program. So with a couple of basic measures like the 6-minute walk test and some questionnaires. So we looked at a variety of different data, so referrers, waiting times, survey data, adverse events to capture these elements of feasibility. So in terms of demand, so the program received 155 referrals in the 6 months that it was running. To put this into perspective with the pre-existing subacute program, the demand was higher, so it was almost double the amount of referrals that we'd receive within a 12-month period for the other program. So there was something definitely to be said of the co-location of the program. 73 referrals were accepted, so uptake was a little bit of an issue, and a lot of the referrals were not received because they either weren't interested or they were potentially being referred too late. They'd already completed their treatment, so they could be referred to another cancer rehab program. So the average age of our patients was 63 years old, which is similar to our existing program. They were about 9 months post-diagnosis, so we were receiving them a little bit earlier on than we usually would. However, we potentially would have liked to have seen people coming a little bit earlier. We had quite a mix of cancer types. So even though breast cancer was the most dominant cancer, which is what we often see in a cancer rehab setting, there was a lot greater spread among other cancer streams, such as our hematological malignancies, things like breast cancer, GI cancers, which was really pleasing to see, because again, with our subacute program, a lot of our referrals are women with breast cancer, because that's where a lot of the promotion and the evidence has come from in the past. We also had quite a lot of people with more advanced stage cancer, so stage 3 or stage 4. And most of them were receiving chemotherapy, which wasn't unexpected as it was a chemotherapy treatment site. We also received a few referrals for prehabilitation as well. So when patients had the option of programs, we were quite surprised to find out that most of them actually preferred to come into the hospital and attend at the centre, with a smaller number doing home-based exercise. We had pretty good completion, so about 81%. So once people were in the door, they did complete the program, but whilst they were participating in the program, adherence was a challenge. So for those who were attending twice weekly, they only attended about 56% of their sessions, and if they were coming once weekly, it was even less, so about 40% of their sessions. So this is much lower than what's reported in randomized controlled trials. And the reasons for them not attending were usually due to them feeling unwell due to their cancer treatment. When we looked at efficacy testing, this was very much in line with what we would expect from randomised controlled trials. So participants had clinically significant improvements in their physical function, their strength. They also reduced their fatigue, and using the EORTC, which is a cancer quality of life questionnaire, they improved their overall quality of life as well as some of their symptoms as well. So it seemed like this particular model of care was working as it potentially should be. And when we looked at the acceptability of the program, everybody loved it. So clinicians loved it, patients loved it. It helped give patients motivation, a sense of control. They loved the individualised nature of the program. We had 53 unique referrers to this program, which in comparison to a couple of other studies that have been done in this area, there might only be 1 or 2 main consultants that refer into the program. So it did seem that it was quite widely accepted. And we did do a qualitative study on the clinician perspectives of implementing this program, and which helped explain these results a little bit further. So it seems that just having this program located on site seemed to change the culture about exercise, rehab and allied health on the ward, which was really positive. And one of the key things was that it was easy. It was a simple referral. They didn't have a million pieces of paper to fill out to send their patients to this program, and they trusted the clinicians. So looking further at practicality and implementation, so there was only 3 very minor adverse events, which were musculoskeletal issues that were pre-existing and were exacerbated. The waiting time was about 20 days. And the interesting thing to note with this is that the reason why it's 20 days and potentially not less is that patients often didn't want to necessarily come when they were offered an appointment quite early. There were many people that just didn't feel ready to participate, so they needed a couple of phone calls before they came into the program. The health service cost was similar to what we've seen in other studies, so about $1,000 per patient, and this is mainly just the cost of staffing. And one of the key things with this program which led to its success was the engagement. So we did a lot of promotion, education to both allied health staff as well as medical staff. One of the really key things that was helpful was a fortnightly newsletter, which we didn't necessarily expect. The oncologists actually opened it. They might not have necessarily read it, but it led to a lot of referrals. We also got our comms team involved, and we're lucky enough to have a national news broadcast, which also helped us with our promotion as well. So overall, this study, the program, it was a pragmatic program that was safe, it was feasible, and it resulted in clinically significant gains for patients. There was definitely a demand for the service, and co-location and ease of referrals was really key. There were some difficulties with uptake and adherence due to their treatment status, which is an area that we could potentially work on with more flexible models. And it was staff resource intensive, and maybe there was a significant cost, but this could be offset by potential reduced health service utilisation into the future, but we just don't have enough cost effectiveness studies in this area yet to see whether it really is cost effective. So this is an area of further research as well. So I'd just like to thank all the patients and the staff that were involved in this project, as well as my research team and NEMICS for funding our pilot.
Thank you, Amy. That was fantastic. It was a great summary of the research. So just noting timing, I might save the questions for a little bit later, and just if Libby, if you're ready to do your presentation. So just introduce Libby Haskell, and she was the winner of the implementation science paper. So if I can just hand over to you, Libby, to give your presentation.
Sure. So I'm just, I think we'd have this all sussed by now, wouldn't you, with Zoom and things. Can you see that?
Yes, you might. Oh, that's perfect.
Excellent. Thank you. Look, thank you very much for the opportunity to present today. So yeah, kia ora from Tamaki Makaurau in New Zealand, day 106 of lockdown today. So it's very exciting to be sharing being around people again at the moment, even virtually. So I'm presenting the paper that that reports the results of our implementation study. And this study was done through the PREDICT network, which is the Paediatric Research and Emergency Departments International Collaborative, which is an Australasian pediatric research network. And I just first like to acknowledge that this wouldn't be possible without the funding from the NHMRC Centre of Research Excellence grant, and personally for me, the Health Research Council of New Zealand, where I was fortunate enough to get a 2-year clinical research training fellowship to complete my PhD. So bronchiolitis is the condition seen most frequently in acute paediatrics, so managing it well is really important. And in New Zealand, we know that our Maori infants have a much higher risk of admission, and those living in the most deprived quintile as well. And in Australia, this is quite old data, but it really hasn't changed, that bronchiolitis accounts for more than 50% of all admissions to hospital of infants less than 1 year of age. And there's a significant cost burden for this, which is mainly through hospital admissions. And the US have reported estimates of sort of $1.7 billion per year. So we know that bronchiolitis, the management is supportive, and really that's hydration and respiratory support. And there's high level evidence of no benefit from clinicians undertaking a chest x-ray, administering salbutamol, glucocorticoids, antibiotics, and adrenaline. And all international guidelines stress the importance of supportive care. And in 2016, the PREDICT network produced and published the first Australasian bronchiolitis guideline, which was endorsed by all sort of key colleges and stakeholders across Australia and New Zealand. And it was from this guideline that we decided to undertake the knowledge translation bronchiolitis study. So knowing all we do, knowing what we should be doing, you know, how well are we managing these infants with bronchiolitis? Well, we're not doing very well at all. So this is internationally a large study of 38 emergency departments just caring for children, found that, and this was done across the Northern Hemisphere, Australia and New Zealand, the UK and Europe, that more than 30% of infants didn't receive evidence-based supportive care. And we've got data from Australia and New Zealand in more than 3,000 infants admitted, and this was to tertiary paediatric hospitals who we think should be doing well. Up to 50% of infants didn't receive evidence-based treatments, and salbutamol was the most frequent offender. So with this in mind, knowing that we weren't doing particularly well, we developed the bronchiolitis knowledge translation study with the aim to determine whether targeted theory-informed knowledge translation interventions could reduce the use of chest x-ray, salbutamol, glucocorticoids, antibiotics, and adrenaline in infants with bronchiolitis compared to passive dissemination of the bronchiolitis guideline. So our study was multi-centred, a cluster randomised control trial with the clusters being the hospital, comparing our theory-informed interventions versus passive dissemination, or really kind of usual practice of how hospitals would disseminate a new guideline. And we developed our interventions following qualitative interviews of clinicians across Australia and New Zealand using the theoretical domains framework, which can help identify key factors influencing bronchiolitis management. And from that, we targeted behaviour change techniques to address those factors. So we enrolled 26 sites across Australia and New Zealand, 6 in New Zealand and 20 in Australia. The hospitals needed to have more than 135 cases of bronchiolitis per year and be happy to be in either arm. We needed buy-in from both emergency department and inpatients because bronchiolitis is managed across all of those areas in a hospital. And we needed sites to be happy to have clinical leads for the duration of the study. And our exclusion criteria were fairly standard. So our primary outcome was compliance or non-compliance for each individual patient with the guideline recommendations during the first 24 hours following their presentation to the emergency department, with regards to those 5 guideline recommendations that we know have no benefit. Secondary outcomes included compliance and non-compliance for each of those guideline recommendations during various time points in the hospital journey, as well as total hospitalisation, length of hospital stay, death or ICU admissions. We collected data retrospectively on a randomised number of infants with bronchiolitis. They needed to be less than a year of age at presentation, and we required the infants to have both an emergency department and final diagnosis of bronchiolitis. So we didn't want to catch people out. You know, if the clinician in ED thought that a child had croup and appropriately gave a steroid, but they were discharged with bronchiolitis, we exclude them from our data collection. And we collected data 3 years prior to the implementation year, and then at the end of the intervention year. So the study was powered to 90% powered to show an absolute decrease of at least 15%, and we analysed by intention to treat, and we had a statistical analysis plan which was finalised before lockdown of our database with pre-specified sensitivity and subgroup analysis. This is just a figure of the flow of the study. So we recruited sites both from our PREDICT network and beyond. Once we got ethics, we randomised them to either intervention or control, and then both intervention and control sites received exactly the same copy of the complete 150-page guideline, as well as the 5-page bedside clinical guideline in electronic and printed format. At that point, we sort of said goodbye to the control sites, and we'll see you later, and you go ahead and do what you want to do. And then we focused on our intervention sites. So we got our clinical leads together. They did a small audit to sort of get a bit of a taste of where they were at with complying to the guideline recommendations, and that was to get some buy-in. They self-chose 4 clinical leads, so a nurse and a doctor from ED and inpatient paediatrics who basically led the study. And then we could fly to Melbourne in those days. So we flew all of our clinical leads to Melbourne, and we held a train the trainer day where we told them all about the study. We introduced implementation science and knowledge translation, talked about how we'd developed and why we'd developed the interventions, and then we taught them how to use the interventions so they could go back to their sites and teach their nurses and doctors over the implementation period. So they were provided with PowerPoint presentation which had key messages targeting the findings we'd identified from the qualitative interviews. There was some kind of fact sheets. We had some posters which everyone loved. We had a caregiver information sheet for families, and then we had a video which showed how you could talk to a family about bronchiolitis, because the interviews had shown that there was a bit of pressure from families sometimes to try things. So we developed that for them to use as well. And then finally, they did 7 monthly audit cycles. So they randomly just chose 20 infants that had presented to their hospitals, and they did a quick kind of review, sent it through to us, and we put it in a little report, sent it back to them so they could sort of see how they were going. And we also benchmarked them against anonymously to the top site, and we discovered that clinicians are very competitive. Everyone wanted to be that top site. Control sites didn't miss out. So right at the end, after all the data collection was done, and we could still fly them to Melbourne in 2018, we did exactly the same for the 4, and we had 4 people from each control site. We gave them all the materials, and we did actually give them some of their own data to take home as well. So we had 26 sites randomised, 13 into control and intervention. We had no sites drop out. Pre-randomisation guideline compliance was fairly similar across groups, and the interventions were delivered as per protocol by the intervention sites. So these are our intervention year baseline characteristics, which were well balanced between both groups in terms of the age of the infants, the gender, ethnicity, as well as past medical history. Looking at our primary outcome of compliance during the first 24 hours following presentation to ED with regard to those 5 guideline recommendations, we found a risk difference favouring the intervention arm of 14.1%, with a confidence interval well away from 0 at 6.5 to 21.7%. Secondary outcomes were looking at compliance for each patient presentation, and this was during time periods within hospitalisation. So we improved over in the intervention sites while in ED, while as an inpatient, and then 14.4% improvement during total hospitalisation. When we looked at each of the recommendations we were targeting, we did have improvement in intervention sites across all of them, with salbutamol being the one that we had the biggest improvement, which is kind of not surprising really, because of the fact that that's where we had the biggest misuse. Things like adrenaline and antibiotics are not such a big problem in this part of the world compared to particularly the Northern Hemisphere, so we didn't have much of a problem there. Length of stay, death and ICU admission remained unchanged. So our limitations were that obviously we couldn't blind our staff because they actually needed to know which arm they were in. Collecting data retrospectively is always problematic, but in fact, the data we were collecting from medical records was pretty well documented. So medications and x-rays are quite easy to find. As I've mentioned earlier, requiring both an ED and discharge diagnosis of bronchiolitis meant that we actually probably think that true compliance was probably lower than we've reported, because looking through these notes, it was very clear that some of these infants had bronchiolitis, but the clinician just didn't recognise that. And obviously this is done across Australia and New Zealand in hospitals of more than 135 presentations per year. So generalising that to smaller or bigger hospitals just needs to be approached with caution. So I guess just wrapping up, I think, we feel happy that we've shown that these targeted interventions can improve the care we give to bronchiolitis, which is really important. Chest X-ray and salbutamol have the higher incidence of misuse, so we had the more chance of improving there. And I think for clinicians everywhere, and I'm a frontline worker, we don't want to be doing things to infants that are potentially harmful, costly. So reducing and kind of de-implementing these kind of things is really important. Sustainability is a topic that's very important, and we're currently going back to our 26 sites to actually see if changes that they made have been sustained over time, and actually interviewing some clinicians to find out what they've been doing over the last couple of years. We were really excited that our paper was published earlier this year in JAMA Pediatrics. Just like to really thank all of our hospitals across Australia and New Zealand who really took this on with gusto. Many hospitals hadn't been part of a research project before, and it was amazing that out of our 26 hospitals, I think 26 of them really wanted to be in intervention. So they were gutted when we said that they were in control. So I think it really highlighted to us as a group that people want to do the right thing and they really want to be part of making positive change. It takes a village to do this. It's been a really big undertaking, but certainly, there's lots and lots of people who have been instrumental in this, and really happy to take questions or comments.
Thank you very much, Libby, thank you. I'm just conscious about time and just wonder if we should hand over to Sophie and Yvette to do their presentation, and then we'll come back to the questions at the end because there's a few that are popping up in the chat.
I think it's a great idea, Marsha. We are running a bit behind time, so just ask the next presenter to please keep it brief and to time.
Good afternoon. I will quickly start while Sophie is at the other end doing all the machinery and the hard thinking. I'm Yvette Rowe. I'm a Ngina Yarra woman from the West Kimberley and proudly stand on the lands of the Larrakia people here in Darwin, and we're really appreciative and acknowledge the award and quite humbled by it. I'm the Professor of Indigenous Health at CDU and also the co-director of the Molly Wadaguga Research Centre. And our focus for our centre is the best start to life for First Nation mothers and babies. So our paper really fits in that scope. Sophie's sorted out the, and I am mindful we're going to get straight to the point. Hold on to your seats, everyone. Sophie's on mute.
Sorry, there's too many fiddly bits. Hi, my name is Sophie Hickey. I am an early career mixed methods health service researcher at the Molly Wadaguga Research Centre. I'm a white woman and settler on Yagara lands.
As part of our protocol, we want to recognise the lands that we are on here, again in Larrakia land and Yagara Turrbal land, but also acknowledge the other unceded lands throughout Australia, and New Zealand, and that sovereignty continues. These are the close to 250 nations here in Australia, so I really want to acknowledge that. And part of the our paper is really critical is that, I mean, I've been blown away by the papers presented. So what we're going to give you is an insight into our methods and methodologies to ensure that you could hear the richness and the passion of the voices of the participants that participated in our study.
Awesome. So just to kind of go over what was in the nomination, this paper, I think it's important to recognise it's a qualitative paper that won this award. So that's pretty awesome. And so in case you were wondering, Yvette and I were joint first authors. And this paper privileges Indigenous voices and knowledges for emancipatory goals. It historicises the current context of sexual and reproductive health inequalities for First Nations people, and highlights the important role of First Nations community members and spaces in providing culturally safe health promotion, and also includes tangible actions for Aboriginal community-controlled organisations to take up. So it's important to contextualise this study historically. In Australia, Aboriginal and Torres Strait Islander people, there's been a lot of colonial control over reproductive rights and sexual well-being. Sexual violence was used to debilitate communities in the early invasion periods, and institutional assimilation practices saw control of marriages and infant removals. First Nations people were fallaciously imagined as highly sexualized or sexually deprived. And this was really a tool to further segregate communities, Aboriginal communities from colonial settlers. So this is the complex historical context in which these health inequities persist. So the WHO defines sexual and reproductive health as a physical, emotional, mental, and social well-being. People are able to have a satisfied sex life and should have the capability to reproduce and the freedom to do so and to decide if that's what they want. And this definition is compatible with holistic First Nations worldviews of health and well-being. So looking at the literature, we can see that a lot of this type of research focuses on sexually transmitted infections and the use of contraception, but very little research includes the views of First Nations men, Torres Strait Islander people, or First Nations people living in an urban setting. And so this project actually came up with from one of our Aboriginal and Torres Strait Islander community-controlled sector partners who were finding that this fragmented literature base was not very helpful to help them inform their sexual and reproductive health strategy. So this study aimed to better understand community preferences, knowledges, and access to contraception and sexual and reproductive health services, and then to use this in understanding to make recommendations specifically for ARCHOs.
And I guess the thing is, the little slide there, let's talk about sex, baby. And often when people talk about sexual health, it's quite an uncomfortable space. So one of the things in our methods was to actually normalise this conversation with the participants that we were talking to. And one of the stuff is that you talk to your own mob like you're making connections. So being in good relations with whoever you were speaking to was really important. And we had young women who were early high schools, we had aunties and nanas, we had young men, we had mothers who had recently had babies. We had a collection of people, we had clinicians who were providing services at the community health services. And it was interesting, there was that awkwardness of how do we have this yarn and why do we need to go into the privacy of people's, behind closed doors? So there was a skill of having the yarn, but also ensuring that we did it in a culturally safe way that people could have a yarn and not go too deep, but feel safe enough if they wanted to go into deep conversations that they could. And then after getting all the yarns together and hearing what people were saying, so what was the best way to sort of make a thread and make some comprehension and feed this back to the sector. And the findings was really interesting. What I think research does as us as researchers is our skill is to be a storyteller and to ensure that we're true to the words that we're hearing. And what we found is that there's two things. There's things about knowledge holders and knowledge spaces. So knowledge holders might, the aunties and the grandmothers, they talked about, well, we want to be there supporting our young people, but I don't know all the suite of medications or contraceptions that I could be providing, my grandchild with. And the next part was, where do I find this information? Because, and Aboriginal Community Controlled Health Services have been in Australia for over close to 50 years. So we've had these spaces. And then we've got the people who want to access that space, but also recognising that people come to this conversation with already some established knowledge. And here's some quote from a young woman. Who is their knowledge holders? Who has this information? I would talk to a friend, an older sister girl, or one of my mates, because that's more comfortable. So we think as clinicians, I'll just go to my doctor, to my health worker. But really, there's other people in the community that we need to be able to give more information to. Again, this is an auntie. It's about being a mother and an auntie and just how to support them. Young girls, hopefully they'll learn from it and they'll pass it down. So one of the things was, have the people who are the aunties and the nanas who are talking to these young people, have they got the most up-to-date information so they can have that yarn? Knowledge spaces. There's lots of places. We think of knowledge spaces as a formal clinical setting, a library, but actually knowledge spaces were considered in community hubs, in groups that were already established, that people could approach the clinician or the health worker. I found that people are engaged more that way, using yarning groups. They ask questions. If you feel unsafe, you don't have to talk. There's an opportunity for us to talk together in a safe space. So we created a safe place to discuss it. Being able to speak about whatever comes to mind, whether it's funny or being able to laugh, helps with engagement. So again, taking that sharp edge out of this conversation that usually makes everybody feel a bit uncomfortable. Again, knowledge spaces. I went to a mainstream doctor who talked about contraception because I didn't live close to an Aboriginal Community Controlled Health Service. And he, the mainstream doctor, gave me a big sheet, a contraception sheet. I don't really trust him, that doctor, because he's he's a man for starters, and he's so medically driven. So although we see as clinicians all trying to do the best for our clients, often it's about the place, the gender, and the timing of the person going to that information.
And then in the interviews, the focus groups and yarns with the clinicians, the message was very much, we'd be so much more successful as clinicians if community conversations are alongside us. The people in the yarning circles also identified that they wanted and needed accurate and timely information in an accessible and culturally appropriate way. And things like waiting times at the clinics were identified as a barrier to access, particularly for that more opportunistic health promotion opportunities when you have to wait 3 weeks for an appointment. And one thing that our male researchers found yarning with the young men was actually that another barrier to access was having a stable doctor. So the young men said that they didn't necessarily feel the need to or feel comfortable with doctors, and this did impact their access to the health service, the things provided by the health services.
So, why did this matter to participants? There's often a myth that people just sort of don't think about this and that there's not a lot of planning behind it. But what we found when we talked to the women and the young men and the aunties and the nanas was people do want to make informed choices. and it's got to be in a place they feel their voice can be heard, and it's on their terms. So that's the thing about your body sovereignty and the choices that they've made. So, and one of those things that we found was often people talked about sex or the mechanics of sex, but then people stepped back and said, actually, we want to be talking about strong families and having healthy relationships. And in my own agency and where I want to go, I'll decide what choice I want to make, whether I want to have a family or whether I don't, or whatever it might be. And all of a sudden, it just took the heaviness out of the air. And we're talking about how do we be in good relationships. So again, it's not all about sex. It's about how do we respect each other, what the strengths people come to the table, and how do we have that conversation in a way that just disarms people.
So some of the recommendations that we made in the paper for Aboriginal and Torres Strait Islander community-controlled organisations specifically about, specifically recognising them as being acknowledged as safe spaces, was to provide a way of supporting the knowledge holders. So recruiting and supporting family, kin and friends as community-based sexual well-being and healthy relationships champions. And then in terms of supporting the knowledge spaces themselves, there was some important work to do about having a consistent message across the organisation that everyone has a role to play in these discussions, and that these are everyday yarns that should be happening about healthy lifestyles and relationships. Some staff identified the need to be updated to have the most up-to-date contraceptive training and education. And it was really important to creatively engage community in sexual and reproductive health promotion and education activities. So really find funny and different ways to do this. And there were some suggestions from participants. And then also so that it doesn't kind of go under the radar and the archers can keep an eye on how this is going, to incorporate sexual and reproductive health into its continuous quality improvement activities.
I guess if, in the sense of if you remember anything from our paper, is that the importance of that everything is related, the importance of community relationality. Often we think of people as the intervention, but actually what we need to be thinking is the collective. How do we support the individual to have agency and to make informed decisions across the spectrum, across their lifespan, and also the people who they're seeking information from? How do we support them to ensure they've got accurate and timely information and where to go? Aboriginal community-controlled health services have been around, like I was saying, for 50 years. Again, this is another piece of evidence that show that it is an acceptable knowledge space for people to go to get information about contraception and birthing choices. The other thing is, health services should be considering upskilling community knowledge holders. We can't expect people to go into a clinic and then access the information. The service has to go out to the community and have those conversations, which is disarming, which is engaging, and which is timely.
So since this research was done, this was able to inform IUE's sexual health and also men's health strategies. IUE used our early findings to make a health promotion video, which you can catch on YouTube. And we've also got a community report available so that people can read in a easy to read way the main things from the paper.
And I guess there's sort of in the stuff, what does this mean for research and our team, and what does it mean for health services research? Is that we see research as a transformative tool. Yes, we are storytellers with quite a specific focused purpose. Is that we know that we can do better with our health services and ensure that it's responsive to community needs. We realise we all come to the table with our own little story and our expectations, so acknowledging our biases is really important. Like I said, there were some researchers that said, well, don't we want all young people to have better choices? I'm thinking, and you'd have that conversation, because young mums struggle. I'm thinking, that's your bias. Yeah, we know young mums that are thriving and young dads who are thriving. So let's not all have this sort of this deficit-based lens on them. You know, the First Nation community is really creative and responsive to problem solving, and we've got to get them at the table. And finally, we want to do more, we need to do more, but we also want to make sure that it's uplifts the community, it's quality work, it's meaningful, and it's also of use.
So this was actually a small study that was done with very little funding, and was able to support a master's student project with us, and it's just an example of what can be done when you don't have much resources. So if you like the kind of work we do have student opportunities available with the team. All right, thank you.
Thank you for the opportunity for talking, and we really again appreciate the acknowledgement of the work that we're doing and the work that we're going to be doing in the future.
Thanks.
Thank you very much. Thank you, Yvette and Sophie, very much for your talk. Marsha, I think we're out of time in terms of questions for this session. So what I might suggest, if Sophie, Yvette, Libby, Amy, and any other questions for Jill, if you could put them in the chat over the next 10 minutes before we finish up with the end of year event. And if those presenters would like to follow up individually, I think that'll give you an opportunity. So I'd like to thank all the speakers, and particularly like to thank Marsha Somi for being the session chair for our prize-winning presentations today. Thank you. Okay, now I'm going to spend a few minutes just wrapping up the event today, and give you a reminder also about the AGM, which is a separate Zoom link, and that will be starting at 3 o'clock, 3 o'clock Sydney time. So the first thing to say is the Health Services Research Association is really the peak professional body for people conducting, interested in, disseminating and using health services research. And so we do encourage you, if you're not a member already, or if you're not part of a group or a team who's a member, that there is a membership opportunity that's available to you at different levels, either individual, partner centre or team. And all the details are on our website. I'm just going to reflect on the speakers that we've had in the program today. So first of all, it's been really informative and a really good partnership, I think, to be engaging with the main funding organisations for health services research. So Anne Kelso representing the NHMRC, Luke Garland representing HRC New Zealand, and Marsha Somi representing the Medical Research Future Fund in Australia. Now, picking up on a common point that both Don Nutbeam and Amahir Bolton talked about in terms of how we direct health services research to reduce health inequalities. And that, for me, that message that came out loud and clear was that universalism does not work to improve the health of disadvantaged peoples. And I think this is a really important theoretical and practical point, because one of the, I guess, main arguments about directing resources to one group of people is that if you improve the health of all, then you'll naturally bring up people who are disadvantaged. But there is enough research now to show that that has been the dominant strategy, but it hasn't really been reducing the gap in inequalities. So I think that was a really important point. I did like how Don had talked about, we have a lot of data on observing health inequalities, we have less on engaging. And particularly the priorities, as he saw them, about how overall improvement in health masks the widening of the gap, the increase in inequities, how exploring proportionate universalism, how it can be applied in practical ways, and health services research can be funded to have direct programs exploring disadvantaged groups and factors. Developing, testing and funding organisational interventions that are known to address variations in care, and it would be really good to see specific funded schemes that help us to tailor our applications to that type of research. Focusing attention on the worst off or the poorest 35% of the population. And also that the health system is very important as in local economic activities. So really exploring a lot of the complexities around reducing health inequities. And then Amahir's talk, which was absolutely terrific, was very, very interesting to me as a person who lives in in Australia. The underlying principles and the concept of flourishing as Maori. And obviously the catch there being that in the non-Maori or the dominant health system in New Zealand also needs to meet the needs of Maori. So I really was very interested in the 3 projects in this program. Really look forward to hearing about the new knowledge that's developed, particularly the leadership in decision making, which as a health economist is where I've probably had most of my research interests, but also the work on the home environment and strengthening primary care that works for Maori. And then the 4 presentations today from our award winners. Jill Gorham really it was a myth-busting presentation, I found, showing that remote dialysis for kidney disease is less expensive than in-centre when all relevant costs are taken into account, and is also more preferred to dialyse on country. Amy Dennett's presentation, I found really interesting, the use of the Bowen's framework for feasibility, and would certainly like to know how suitable that framework was. Libby Haskell gave us a really nice example about the importance of randomised controlled trial design when you're assessing implementation interventions. And then finally, we heard from Sophie Hickey and Yvette Rowe, which I think was an excellent example of qualitative research. It's a really interesting topic, normalising sexual health yarning for health promotion, and how it was done in a culturally safe way. And then the factors, not so much even about the content, but those other factors about the place, the gender and the timing of the talking and the yarning about the topic that really made the difference. So I think an excellent day, and I'm sure you'll all agree. Now, just to let everybody know that our conference will be a face-to-face event in December next year. It will be held in Sydney at the University of Sydney, and the registrations are live now. So if you, for instance, have funds that need to be expended before the end of this calendar year, feel free to register for the conference. And then finally, our AGM, which will be starting in about 2 minutes, is a separate Zoom link, and I think that's also going to be placed in the chat, but otherwise you have an email that has the Zoom link to it. So I look forward to welcoming many of you to the AGM. Thanks very much to our organisers for the event today, Alison Pearce and Sarah Green, and to everybody else who's participated, and to Tilly Payne for the mentoring session as well. Look forward to seeing you soon.
Thanks everybody, and just to say, if you just scroll up slightly in the messages, there's a link there. If you haven't registered already for the AGM, you can do that now, and you'll get a quick email with the Zoom link to join us.
Terrific. Thanks very much, Sarah.